Welcome to the deep dive. Today we're tackling vasculitis imaging, specifically honing in on what you, as an interventional radiologist, really need to know. We've sifted through a lot of material, and the goal here is simple. Extract the essential imaging nuggets that will help guide your practice.
Yeah, it's a complex area. Vasculitis, it's basically inflammation of blood vessel walls. And the big challenge is that symptoms can be, pretty nonspecific. That 2012 Chapel Hill classification helps, though, sorting them by vessel size. That really points us in the right direction for imaging.
Okay, so building on that, let's talk imaging's role, especially for the large vessel types, the LVVs. Biopsy there is often tricky, right? So what's imaging really doing for us?
Oh, it's absolutely critical. We rely on it for the initial diagnosis, definitely for monitoring how things are going, and importantly for us, planning and guiding interventions. And something really key, particularly for IRs, is the timing. You ideally want those images before they start immunosuppressants.
Ah, right, because the inflammation can just disappear on the scans.
Exactly. Those active signs can fade incredibly fast once treatment kicks in. You lose that crucial diagnostic window. It can feel like a race sometimes.
That timing point really hits home. You need that clean baseline. Okay, let's break down the tools. Ultrasound first. What are the key things for an IR to look for with ultrasound?
Well, ultrasound's great value, right? Cost effective, no radiation, especially good for vessels closer to the surface. For GCA, giant cell arteritis, you're looking for that classic halo sign.
That hypoechoic thickening.
That's the one. Circumferential, hypoechoic wall thickening, it's pretty much pathognomonic. Plus, you check for the compression sign and obviously any stenosis or blockages. For Takayasu, maybe you'll see this sort of homogeneous mead-coic thickening around the common carotid. The main limitation, as we know, is depth. Can't see everything.
Right. So for deeper structures and more detail, we usually lean on CT and CTA. What are the signature findings there that we should be zeroing in on?
CT gives fantastic spatial resolution. Great for seeing the structural changes. In Takayasu, look for that concentric thickening of the wall, sometimes that double ring enhancement, maybe the rat tail sign, that tapering stenosis in the descending aorta. Now, for PAN, polyarteritis nodosa, the real hallmark is microaneurysms, tiny things like 1 to 5 millimeters popping up in hepatic mesenteric renal arteries, often alongside stenosis too.
And finding those microaneurysms is crucial for us, isn't it? Potential bleeding risk, targets for embolization.
Absolutely paramount. And CT is also vital for seeing the downstream effects, like lung nodules in GPA or those significant vowel wall changes you might see in lupus vasculitis.
Okay. But radiation is always a consideration, especially in younger patients. So MRA often gets the nod. What's its unique advantage?
MRA is actually first line for Takayasu, generally recommended. It's just better at showing the mural inflammation itself, the thickening, the enhancement, and often it picks this up before the patient even has clear symptoms.
That early detection capability sounds like a huge plus.
It really is. Big implications for starting treatment sooner. MRA also gives great detail on coronary involvement in Kawasaki disease, and it's definitely the most sensitive, non-invasive way to look at CNS vasculitis. It gives you anatomy and some functional info, like assessing the heart muscle in eGPA.
And rounding out the big modalities, PET-CT. That seems tailor-made for seeing active inflammation, right? How do we best use it?
You hit the nail on the head. PET-CT is excellent for pinpointing active inflammation. It shows increased FDG uptake in the vessel walls where things are hot. Especially good for LVV, like GCA and Takayasu. Generally, if the vessel uptake is higher than the liver's uptake, that strongly suggests vasculitis. It gives you a whole-body look, often finding disease earlier than other methods.
But there's a catch, isn't there, with uptake persisting sometimes?
Exactly. That's the crucial point. FDG uptake can hang around even when the patient's in remission, probably due to chronic changes or maybe low-grade inflammation. So you absolutely must correlate PET findings with the clinical picture and other imaging. Can't rely on it in isolation.
That makes sense. So, putting it all together, when we're faced with these images, how do we confidently separate true vasculitis from all the things that can look like it, the mimics?
That's where understanding these specific patterns is so critical. For LVV, think about aortic dissection that's usually eccentric thickening, right? Vasculitis tends to be more concentric, or atherosclerosis. On PKT, throw usually shows patchy uptake. Vasculitis tends to be more diffuse, more circumferential along the vessel.
And for smaller vessels, say in the gut.
Right. For small vessel vasculitis affecting the GI tract, look for things like skip lesions or involvement in odd places like maybe the duodenum or jejunum where you don't typically see ischemia or IBD. Those patterns point more towards vasculitis. It's these subtle differences that guide our next steps, especially interventionally.
Okay, so we've covered a lot of ground on vasculitis imaging. The real key for you listening in is knowing which modality gives the best insights for different vasculitis types and, crucially, what those findings mean for managing the patient.
Absolutely. It's about leveraging those distinct signatures that halo sign on ultrasound, those pan microaneurysms on CT, specific patterns of FDG uptake on PET. Recognizing these helps us guide interventions much more effectively and ultimately improve outcomes. And the field isn't standing still. There's exciting work on novel PE tracers, hybrid imaging, pushing towards even greater precision.
So, the takeaway. Next time you pull up complex vascular imaging, remember these patterns. Think about what they're telling you about that underlying inflammation. Keep asking questions, keep learning, and keep diving deep into those images.